All right. Well, I hope you had a great discussion. I know the time was not enough. When a lot of people come together, it becomes chaotic. But that's when the great ideas happen. Let's continue the discussion further. This is our LinkedIn group. Gilbert, can you? This is our website, and our next meeting is on January 9th. We meet the second Wednesday of each month from 6 to 8 p.m. This is the first time we got together. I'm expecting the crowd to grow bigger. I reached out to Microsoft Nerd, and let's see if they can offer us a space. Gilbert, can you please point out to that? If you see here, we have our Facebook, Twitter, and LinkedIn. We're going to continue our discussion on LinkedIn. I know most of you didn't have enough time to continue and come to a conclusion, but let's summarize whatever we talked about, and we can continue the discussion on LinkedIn. I'm also going to share a Google Doc. I highly encourage each one of you to reach out to other people to collaborate. If there's anything I can do to help you, if there's anything I can do to connect you to other people in the healthcare, look at my LinkedIn profile, and I'll be happy to do so. So okay, Gilbert, can you please click on the LinkedIn, this icon? So this is our LinkedIn page. I highly recommend you to come here and continue the discussions further. So let's get started with our first group. Patient experience, profitable business models, and health insurance card connected to the ATM card. Who would like to summarize the discussion?
Okay. Thanks, Noel.
Sure.
So,
Tell us your name again.
my name is Chris Harrett, and we kind of combined all those topics and had a kind of wide-ranging discussion about business models and healthcare. We had one colleague from Germany who helped us understand why the Germans live longer and pay less for insurance than we do. We talked about a lot of different ways people would, services people got, not just in medicine, but other things related to health. But I think that what came out of it, this interesting summary, was all the different revenue streams that can flow into a healthcare company. I mean, there's the obvious one of selling fee-for-service, which is a model that maybe be going extinct in the United States. But so if you're just going to look at the different revenue streams that might come into a business, whether you're providing health care directly or you're selling technology to healthcare providers, there's getting reimbursed from the insurance company. That's the old one. But there's also getting the patient to pay directly, things like concierge medicine services or health-related wellness services. There's getting employers to pay to keep their employees healthy, helping organizations avoid costs, whether it's readmissions or office or supplies or whatever. There's advertising. It turns out quite a few businesses supported by advertising. But one of the most surprising ones actually was selling the data. And that's one of those sort of parts of a lot of business models it's not obvious, but we started to uncover stories about companies where they appear to be in one business, but what they're really doing is gathering data on patients or on consumption or whatever, and then monetizing that somewhere else.
Hold on, Chris. Does anyone have anything to add to Chris's summary?
That's what pharmaceutical companies do with clinical trials. They get the actual data. They may not get patient names in terms of trials and stuff. And then they pretty much collect that data and monetize it in ways that gets it.
That would be the granddaddy of all of these.
It's actually called big data.
Yeah.
Are we referring to economy on Monday, transition in healthcare? They were discussing big data, and that's nothing else. The data is neither big nor hugely interesting, but it's extremely valuable. It's just finding ways to basically extrapolate this data, which is basically existing, but to somehow capture it. That's basically the whole concept behind it. As simple as that.
Thank you, Chris. Where's that neck? People from Sao Paulo, sorry, Caracas. Digital, what were you talking about?
We were over here.
Oh,
It's
sorry.
in my,
Raghu and Yuri. Well, who wants to summarize from your group? Simon? Satish?
Satish was there.
Anyone would like to summarize?
I'll go ahead.
All right.
I'll give it a shot. Okay, we thought about the problems with the information not being in different silos at each places. It was experience from you go to a hospital and you check in an ER. They don't have any information about you because you normally go to a different hospital, and then one of the I think it was you who pointed out, you take your car to a car dealership, and then you used to go to, I'm sorry.
You might want to summarize what was the topic and then discuss, because people
Sure.
are lost.
Sure, sorry. We were lost, so that I'll try to. The topic we were trying to discuss is why can't there be a system where the information gets exchanged freely so that it's available at least in a geographic area for where the patient goes in, it's available for the doctors to treat, and not necessarily trying to reinvent the whole. So that was the problem we were trying to discuss, and one of the technologies. The conclusion was the technology is already there, because you take your car to a dealership and you take it to a different dealership. They know what repairs was done in the other. So why can't? And they know a lot about your car, but not about yourself. So that was the gist of the discussion. But again, it all came back to why it's not the technology problem, it's a process, security, privacy, it's a whole lot of different issues. It's not as simple as let's make it, all common technology on a common framework. Not as simple as that. It's like, there's HIPAA regulations, there's regulatory factors that come in play, there's different EMR systems which went off in different tangent by themselves. Economy comes in place. They don't want to share data because if you share data with a different doctor, and what happens if the patient likes that doctor instead of you? So there was a lot of other factors that came in place, and we discussed different factors that came in place to prevent actually what is supposed to be a more commonsensical way of dealing with the problem, so that it helps the patient in the end, rather than the whole other players within the healthcare systems. So that's what we discussed.
Thank you. Does anyone have any comments, suggestions to Raghu and his team's discussion?
I think one kind of interesting thing that comes out of everything that we're talking about, it's obvious, but even if the HIE comes about and all the data flows through it and you can move data from one clinician to another, if you're talking about, say, big data, or maybe it's not big, but data analysis, you still actually can't do it, because the data technically still belongs to that patient and can only be sent over to another clinician that's using it for that patient. No entity can actually go in there and take all the data that's been collected and analyze it. That legally isn't possible. So it's still a problem in the entire industry, or maybe it's opportunity in the entire industry, to collect data, aggregate it, because you can do that as a company. You can aggregate your own data and anonymize it and then figure stuff out from that. So it still is this play of who can access as much data as they can that's useful and come up with something from that. And the HIEs don't